Good morning, everybody. I would like to invite the presenter for the first talk on septal VT ablation, the case presenter, Dr. Janaka Patraj, and the case discussion will be held by Dr. Asungu Dunuila. I invite them to take the stage.
Good morning. First, let me thank Dr. Stanley Amarasekara, the President of Sri Lanka College of Cardiology, for giving us the opportunity to start off the session. It looks quite strange to talk in front of an audience. It's virtually empty, but let's consider this as the new normal, as everybody says, and start off the session. Our session consists of two case hypothetical scenarios plus a discussion which follows. To start off, we'll do the two case presentations. Dr. Patiraj will first present the two cases, and then onwards I'll take up the discussion part of it. Over to you, Jan.
Thank you very much. First of all, I would like to thank the organizing committee of Sri Lanka College of Cardiology for giving us this opportunity. Today topic is septal VT ablation. So I will give you two case scenarios just to give some idea about how these cases present to us and what is the clinical picture like. Then Dr. Dunuila will continue with the discussion of how to diagnose and do the ablation. Our first patient is 16-year-old boy, previously healthy school boy. About 3 months back, patient was perfectly well and doing his normal day-to-day things and engaged with physical activities and sports. But over the last 3 months, he deteriorated in his physical fitness mainly. He was experiencing progressive exertional shortness of breath, and he was unable to keep up with other children in his same age, and he is getting very tired easily. So apart from non-specific chest pain and sometimes the fluttering of the chest, there's no any significant history of any illness, there's no any fever. Then because of this complaint, patient was seen by a consultant physician and normal blood investigations were done. And all the basic blood investigations, including thyroid profiles, were normal. And then at that time, he decided to take an ECG, and ECG was taken and found to have tachycardia. And he diagnosed it as a supraventricular tachycardia, or SVT. And by the time he examined the patient, the heart rate was in normal range, so he decided not to admit the patient. Then he started him on bisoprolol 2.5 twice a day and referred him for further assessment to a cardiac electrophysiologist. By the time this cardiac electrophysiologist in the patient, heart rate was 150 beats per minute, blood pressure was 90 by 70 millimeters mercury. Yeah, this was the ECG taken taken by the VP, and you can see when you look at the ECG, there's a tachycardias there, regular tachycardias there. Complex are relatively narrow, and there's a right bundle branch block pattern, and there's a left axis deviation. So with these findings, we diagnose this as a posterior fascicular VT. Yeah. So, but the presentation is progressive shortness of breath with the history of tachycardia. It's unlikely patient to get a progressive shortness of breath in this nature. So we decided to go ahead with a echocardiogram to assess the cardiac function. Can you play it again? This is the echocardiogram. You can see there's a severe impairment in his LV function. So this is the first case scenario, and subsequently this patient has undergone coronary angiogram as well as cardiac MRI, both normal. Our second patient is 24-year-old male. He's actually army soldier. He also fit and well, and while he was doing his normal physical exercise sessions in the morning, he developed palpitation and dizziness, and he was admitted to ETU for further treatment. During last 1 year, he had similar episodes few times, and in 2 occasions he totally lost his consciousness as well. And he admitted to hospital 3 times during last 1 year due to the same complaint. And he was seen by neurologist and cardiologist, and all the basic assessments were done, including all blood investigations, ECGs, EEG, CT head, echocardiogram Holter, all investigations are normal. Then he was referred to cardiac electrophysiologist as an outpatient, and he was waiting to see the attend to the clinic. During that time only he got admitted this time. There's no any family history of such illness in the family, and there's no any family history of sudden cardiac death. There's no any recent significant illness or fever. On admission to the ETU, heart rate was 160 beats per minute, blood pressure was 90/60, oxygen saturation on air was 94%. Then ETU consultant has seen the patient and decided to cardiovert, and he was successfully cardioverted to sinus rhythm with a 100 joule shock. This was the ECG taken at the ETU. You can see here also there's a regular tachycardia, slightly broad complexes with a right bundle branch block pattern with a right axis deviation. We diagnosed this as a anterior fascicular VT. That is actually the two cases I had to present. Then Dr. Dunuvilla will continue with the discussion and how to diagnose and how to manage and how to do the ablation on this patient. So thank you very much, and I'll hand over the podium to Dr. Dunuvilla. Thank you.
Okay, the two examples we shown were fascicular VTs of two different configurations. One is the commonly diagnosed, the first one is the commonly diagnosed the posterior fascicular VT, which often gets mistaken. I'll show you certain slides down the line. And the other one was an anterior fascicular VT, which often gets mistaken for some other varieties as well. Now, since our topic is septal VT, we'll also have to consider that some of the septal VTs are actually scar-related ones, which may be more common than the idiopathic VTs. So I thought I'll just mention it right at the start and take on the discussion about fascicular VTs as we go down the line. So this is a scar VT, which is due to a septal scar, which happens due to a previous MI. This is often seen, and these patients have a different history to what was presented earlier. These patients are slightly older in age group. There's normally a history of a myocardial infarction, and then they get admitted with real emergencies like blood pressures crashing and patient in a collapse state. And so this is a different scenario. Now here there is no diagnostic difficulty. It's a wide complex regular tachycardia with that kind of history. You straight away diagnosed scar-related VT. And so this is the first scenario which can happen. So this is the typical diagram that we would show whenever you have a VT or most other arrhythmias. There is a circuit that is going to be in place. Then there are scarred areas, and there are areas which are live, where the electrical impulses, when originates, has an exit point and an entrance point, and the exit points may be in two different directions. So this is a diagram which is shown often when we talk about scar VTs and any other scarring for that matter. Right. Now let's switch our attention to the proper idiopathic left ventricular tachycardia. There are several groups when we talk about left ventricular tachycardia. The commonest variety is outflow tract ventricular tachycardia, which is exceedingly common in South Asia. So we would put it right at the top. There are many varieties: right and left ventricle outflow tract, right ventricle outflow tract being the commonest, and the other ones are less common. And then comes fascicular VTs, and this is the second commonest, and it accounts to about 15% of the idiopathic tachycardias. Then this is where our focus of attention is for this particular lecture. The common variety is the posterior fascicular VT, and then you get anterior fascicular VTs, and also some odd varieties like interfascicular VTs and upper septal VTs and so on. Then there are other ones which you see occasionally, like mitral annulus, tricuspid annulus VTs, and few other miscellaneous varieties. When it comes to fascicular VT, as I said, it's the most common variety. Zipes described this in a manner of a triad, where the induction can happen with atrial pacing, which has a right bundle branch block with a left axis, basically a superior axis, without a structural heart disease. and with a relative narrow QRS duration. Because of this pattern, it often gets misdiagnosed as a supraventricular tachycardia and is treated in a similar manner and also responds. So it gives a degree of confidence saying that it is actually SVT. However, because of the circuit which is quite close to the his bundle, it is also verapamil sensitive. This was demonstrated by Bell Hassan in 1981. Also taking into account the case scenario we presented, the natural history is usually benign, otherwise fit individuals who are quite young, and most of the cases we have seen are the young adults in their teenagers or the early 20s, which present in the manners that we described. The salient features here would be, although they complain of palpitations and chest discomfort, the onset of tachycardia is generally related to exercise, and that's due to the nature that it is catecholamine responsive. So as a result, during exertional activity, these tends to come on. Almost all the cases we have seen in fascicular VTs are males, but the incidence is about 80%, 60 to 80%. Can become incessant. I think we have seen at least 2 cases. One we saw in cardiologist some time ago, and then I think latterly our moderator Dr. Sujita Amrasingh has also seen another very similar case where they present actually in heart failure, and so that's a rarity, but it's seen. Sudden cardiac death is not commonly associated, and QRS complexes are, as I mentioned, they are relatively narrow. The 3 varieties, as I said, the most common one is the posterior fascicular VT, and there are 2. Then the uncommon variety of anterior fascicular VT, the second scenario that we presented, and then exceedingly rare upper septal VTs, which I have seen only couple of cases. Rather a detailed description on the table. It mentions the incidence, how common that is, and the QRS fit, which generally in and around 120 milliseconds. In and around 120 milliseconds. They mostly present with right bundle branch block. And the tachycardia circuit is again a re-entrant circuit which consists of the slow components as well as the fast components, and the slow component being abnormal fascicular area where there is slow conduction zone, which is verapamil sensitive, and then it uses the retrograde limb as either the posterior fascicle or the anterior fascicle. This is the diagram which can explain this. If you see right at the left hand corner, you can see the left bundle which is there, and as drawn, the anterior fascicle and the posterior fascicle is drawn separately. Anterior one more anterior, posterior one more septal, and the yellow star shows the area where it enters the slow conduction zone, which is given by a certain potential called P1, which is actually a diastolic potential. Then it migrates along the abnormal abnormal Purkinje fibers and then enter into one of the fascicles. And so in posterior fascicular VT, posterior fascicular VT, it re-enters the retrograde limb right down there at the bottom of the diagram, and in the anterior fascicular VT, it enters at the top. The ECG demonstration, just to recap, we start off with the posterior fascicular VT. You can see it is right bundle branch block morphology with superior axis, meaning L2, L3, AVF are negative. So in the diagram, we can see again at the bottom where the bottommost arrow is, that is where the posterior fascicle is, and the circuit is basically located there. And then the other corner, anterior fascicular VT, I think it's very weak. Anterior fascicular VT, it's at the top. But the circuit is in the almost the same place. The turnaround point is in the anterior fascicle. Then you get this odd variety upper septal VT as I described, exactly like a narrow complex tachycardia. It's impossible to diagnose on the ECG. Sometimes there is slight VA dissociation, and is only diagnosed during EP studies. Now, this is again another posterior fascicular VT, and this is one of our clinical cases. In this case, I think it is not too difficult to diagnose. I think QRS is reasonably wide, and the axis is, as I said, superior, being L2, L3, AF being negative. To recap on the anterior fascicular VT, same kind of morphology, right bundle branch block, but L2, L3, AVF are positive. That's due to the fact that it's conducting retrogradely to the anterior fascicle. So it has, so it shows positivity towards the inferior leads. The upper septal VT, the rarest of them all, and you can see it's just like a narrow complex SVT. And if you look carefully, there are odd P waves falling here and there, and there's a slight VA dissociation. We never really expect anybody to diagnose this. And if we do a study, if the tachycardia is resistant, we'll be able to identify. Now, what are the diagnostic clues? Now, the confusion here is to differentially diagnose from supraventricular tachycardias, because often it is managed and as a supraventricular tachycardia, and it also works, apart from few odd symptoms that I described at the beginning. So, the differentiation from the SVT on the clinical background, normally it comes with physical activity. So, you have to have a little bit of a suspicion, although there are many other tachycardias which come with physical activity. This is one of the things that one must remember. And then pre-syncope and syncope is a common feature. There is uncommonly in some of the other arrhythmias also you can have pre-syncope or syncope. For example, AVNRT, at the start patient can get pre-syncope, but patients generally don't become syncopal. Of course, there are other varieties. So, these are some diagnostic hints that you can take from the clinical scenario. On the ECG, it's mostly a pattern recognition. If you see a right bundle branch block and a negative L2, L3 AVF, meaning right superior, it's superior axis, there's hardly any SVTs which gives that configuration. So, you have to have a pattern recognition at the start. Treating with verapamil is absolutely fine. Verapamil terminates the tachycardia. And then during tachycardia, if you look carefully, there may be VA conduction, and it's normally because the patients are young, it's 1-to-1. So, you can see a notch appearing at the QRS to indicate one-to-one conduction. And then I think the most prominent feature is the axis change. Once you reverse the tachycardia, there's generally axis change from sinus rhythm to tachycardia. You can look at the two diagrams here, and the sinus rhythm ECG shows axis which is very different to the tachycardia axis. So, this in all these features in combination will help us to diagnose the fascicular VT. Of course, if electrophysiology is seen at the start, they will straight away diagnose this, and but these are the general clues that one can go through. Now, management of fascicular VTs, as I said, as an acute measure, verapamil intravenous is quite effective because because the area of the Purkinje fiber area is quite sensitive to verapamil, being close to the conduction system. Direct current cardioversion can be used, and those are the acute measures. But sometimes it doesn't work. The last case I saw actually didn't even respond to direct current cardioversion. We had to give IV amiodarone, right, to respond. So there can be rarities, but that was anterior fascicular VT. The treatment of choice on the long run is a radiofrequency ablation. Normally, catheter ablations are quite successful. It can be successful in the range up to about 90%, especially the posterior fascicular VTs, where we have definite landmarks. Incidence of complication is generally low. We generally don't talk about any major complications here. One has to be a little careful to avoid a heart block and not to ablate too proximally. Of course, potential first-line therapy and only realistic chance of getting a cure. So, basically what you do is, you basically, during ablation, you identify the circuit, avoid the left bundle, and so therefore you can avoid the left bundle and don't go too high to avoid the AV block, and then use several techniques to identify the circuit. And then once the circuit is identified, you generally create a line with starting from one end till the tachycardia terminates. This will sort of show us the circuit and where one can ablate. There's also posterior fascicle and the anterior fascicle. The two starred areas where the tachycardia enters is one has highlighted seeing pre-PP, that is called a P1 potential, and that is the place where it enters, and then it goes right down, and you get a pre-systolic potential as shown in the bottom graph. That is where it exits and turnaround point and enters one of the fascicles. So you will be ablating in and along those areas till the tachycardia terminates. If you map during tachycardia, here the 12 lead ECG taken from a EP system, and you can see ablation catheter is moved from one area to the other, and you can see several potentials at the end of at the bottom. Right? You can clearly see diastolic potentials, which what we mean by diastolic potentials is the artifacts like thing or the high amplitude signals in between the QRS in the ablation catheter. Right. We can also do pace mapping to identify whether you are in and around the circuit. So this is the same case which we have done a pace mapping, and to prove that we are within the circuit. Normally, if the patient is in incessant tachycardia, by going through the signals, you should be able to terminate the tachycardia during ablation. But that's not really the end point. Then we identify the potentials and then provide further consolidation pulses by going to the diastolic potentials and the pre-systolic potentials to grab the entrance as well as the exit sites. Our catheter positions, normally it's a 3 or 4 catheter ablation, and circuit, as I said, is on the left side, and you need some right-sided catheters for diagnostic purposes, especially if the patient is having incessant tachycardia. We don't want to miss SVTs, therefore coronary sinus catheter should get in. So that's the bottom catheter, and then we need a bundle of his for the mapping purposes. And so if you have right-sided his bundle catheter, then as we ablate, you can avoid that from the left side. What is seen with the right from what is coming from superior, from the top of the picture to the apex side is the ablation catheter, and that is in the posterior fascicle area. This is right anterior oblique weave. So this is the typical starting point of a ILVT ablation. We use this weave much more often than the right anterior oblique position. This is the left anterior oblique position, and where the septum is highlighted with the ablation catheter, you start off from here and then go up looking for the fascicles in and around the area. If it's not found in the standard area, we would move more towards the apical and the anterior side. So this is basically how fascicular VT is being ablated, and normally such ablation takes about anything up to 2 hours or so, but in the straightforward ones it may go pretty quickly. And one has to be particularly careful if one is having incessant tachycardia, where the LV is also dilated. So then the normal catheter positions and the places that we ablate can differ depending on the individual. There's also rare mimics. We probably shouldn't be talking about the rare mimics in this kind of forum, but just to highlight that there are other ones that can mimic the fascicular VTs, probably anterior fascicular VT, not really the posterior fascicle ones. And especially these mitral annular VTs, I think we have seen some of them which can mimic anterior fascicular VT, but circuit is in and around the same area. And here in mitral annular VTs, the ectopics are really more common than the actual VT, and variable sensitivity is ill-defined. Then there are odd varieties like interfascicular VTs. I don't think we have ever seen one unless we have seen in a book, and where it's moving from fascicle to fascicle. So some of the this table differentiates between fascicular VT and mitral annular VT, but those are subtle differences. They are sort of into, that is into deep electrophysiology. So in summary, idiopathic left ventricular tachycardia is a common variety, out of which fascicular VTs are the commonest, are the second commonest, just following the outflow tract VTs. And there are normally monomorphic idiopathic VTs and present with a variable clinical picture from palpitations to syncope and rarely tachycardiomyopathy. Although arrhythmia is non-lethal, symptoms can be disabling. It's often misdiagnosed as SVT due to relatively narrow QRS complexes. It's most sensitive to verapamil on an acute basis, and RF ablation offers the only realistic chance of getting a cure. Thank you for listening.
Thank you very much, sir, for that comprehensive discussion on fascicular VT and ablation of it. I have got few questions through our virtual platform. Looks like the virtual audience has been actively participating in the session. I might have to only limit to a couple of questions. One of the questions, the question is, I will read the question. It's asking, is verapamil superior to amiodarone in treating fascicular VT?
Let me put it this way. I think posterior fascicular VT, verapamil is a better choice, and it gives acute response to the tachycardia, and it generally terminates as tachycardia. I don't think it works that well for anterior fascicular VT. I had tried it, and it generally doesn't work. And taking the last clinical scenario into account, I DC cardioverted the patient thrice. It didn't work, and then amiodarone worked. So I think on balance, for the common variety, verapamil is a much better drug, but in certain other varieties, amiodarone is probably the drug of choice.
I guess in the long term, none of the two
Yeah, in the longer term, none of the drugs work. Actually, they get recurrent symptoms till we do proper ablation for them.
The second question is, when should we consider RF ablation in fascicular VT? I think you discuss it.
I think, because now these patients are, if when you take the clinical scenario, these patients are young patients, and they are unlikely to take medication over a long period. That's one point to consider. And then on chronic basis, verapamil really doesn't control it that well, and you tend to get recurrent symptoms. And also, I think if you present with syncope, we really need to consider that. And invariably, if they present in heart failure, no choice, they are straight into the cath lab.
We keep getting more and more questions. I think we will have to limit the number of questions. Right. We'll have to stop at this level because of the time factor.
Okay,
Thank you very much, sir, and
Thank you
thank
very
you
much.
for both presenters.